the easier part of EKG interpretation is these junctional rhythms and ventricular rhythms. Okay, you won't really have any problem with that because you understand the foundation, the sinus rhythms. Okay, the normal sinus rhythms, the foundation. Everything else is a little abnormal. Okay, so these slides don't really cover a good junctional rhythm, but we'll look at it over here with my expert drawing. Okay. A junctional rhythm, the normal rate is between 60, you could say 59, right? But 60 to 40, right in there. So a junctional rate is going to be slower. You could have a junctional tachycardia, okay, that we'll look at in a minute. You could have a fast junctional rhythm, but the normal junctional rhythm is 40 to 60. It's abnormal because the fact that the SA node is not depolarizing. Something has happened to the SA node. Oh no, right? So so you can identify this as junctional because there's no P wave. Remember, a P wave signifies what? SA node depolarization, okay, or atrial depolarization. You're correct with that. There's a different term. So atrial depolarization or SA node depolarization. Okay, so there's none. There's no SA node, so there's not going to be a P wave. If there's an SA node, then you'd have a P wave. So really, the most common is this one right here in a junctional rhythm. There's no P wave. It's absent P wave. The other one is this one here. That is, I don't know, the most common junctional rhythms that I've seen as no P waves. Okay, but because this is in time, correct? So keep that in mind when you're looking at these two here. No P wave, very common. The other one is the P wave is inverted. So it's upside down. It's there, but it's inverted. It's a sign of a junctional rhythm. That P wave's inverted because of time. There's a time lapse there. Okay, well, there's a problem with the conducting system. Okay, and then expressly a time problem is when the P wave follows the QRS complex. Okay. What you have to keep in mind if you have this scenario here where it follows the QRS complex is not to try to make this a P wave. That'll make a lot more sense when we talk about heart blocks, because the problem with the heart block is you have more P waves than Q waves, QRS complexes, okay? So more P's than Q's, okay? Don't try to make that T wave into a P wave. Know the difference in the way that they look. Okay, so a P wave, it follows because it's just a delay in conduction. Okay, so it's going to follow this QRS complex. So 3 ways you can identify a junctional rhythm is no P wave, most common, inverted P wave, or a P where it precedes the QRS complex. All right, so one of those 3, normal junctional rate, 60 to 40. Here on the sides is talking about a premature junctional complex, or PJC. Remember PACs? Premature atrial contractions. It's going to make the rhythm irregular, correct? Okay. For some reason, that atrial, remember it's atrial because of the P wave. Okay, so it's atrial. For some reason, that atria, one of those atrial cells contracted. Okay. You have, hold a moment, hang on, my mind's like spinning right now. Multifocal and unifocal, this will play a part in PVCs in a minute, okay, where they all look the same. Unifocal, it's firing from the same foci, or it's firing from the same cell. Multifocal means it's firing from different cells. So that atrial beat is going to look different. Okay? Remember that? Remember that part? So PJCs are the same as PACs, except that they originate from the junction. They originate from the AV junction or the AV node. That they don't have P waves, but they might be inverted, or they might be here. Okay, typically there's no P wave. So for some reason, at that junction, it decided to prematurely depolarize, producing a premature junctional contraction. Everybody good with that? Everybody see that? It's the same as the PACs, except it's coming from a different location. Everybody good? Okay. Insignificant, it's just as long as there's not too many. As far as patient care is concerned, the QRS complex it's a regular rate except with the premature beats, okay, just like a PAC. It's in this normal range of the junctional part. P waves, like we just said, they may come up after the QRS complex, they may be absent, all right? And then the QRS complex itself in width is normal. It's a normal width, less than what? How many little boxes? 3, less than 3 little boxes, 0.12, 0.10 to 0.12, okay? The normal width of a QRS complex. And so we look at the rhythm itself. Where is that PJC at? Which beat? Where's identify the PJC in here?
Is it like
It's going to be right here, correct?
where?
See, this is regular, regular, regular. Then this is not regular, right? See the width
yeah.
between the QRS complexes? It's not this distance here. It's not the same with this distance here, correct?
And it looks different too.
And it looks, yeah, exactly. It looks different. Okay. Now this underlying rhythm is what?
I see it now.
If I don't have anything to cover that up, really, but if you just looked at these complexes here, what is that? What? Somebody said it, I thought. Sinus rhythm. Yeah, it's regular sinus rhythm. Okay? So this is the underlying rhythm is a sinus rhythm with a PJC. So it started out sinus. The SA node's depolarizing here. It's a regular rhythm, okay? But for some reason, that junction, that AV node decided to depolarize. Why? Who knows? Who cares? So as long as it doesn't happen, just like a PAC, okay? As long as it's not symptomatic, it's not a problem. No symptoms, no problem. For the most part, right? Okay? So you have a PJC. It's just a premature beat that originates from the junction. Remember, the underlying rhythm here would be sinus. This is not a pure junctional rhythm here. Okay? Good with that?
Mm-hmm.
Then you have junctional escape beats. Okay? It's usually in the same range. Okay? It's regular except for these late beats. Okay? The P wave in the junctional is it may occur after, before. Okay? The PRI, what's it say, it's less than 0.12, so it's not a block. If there's no P wave in the QRS complexes, there's no PR interval, right? You can't have a PRI without a P wave. And then the QRS complex is sort of normal. So this is sort of a weird looking rhythm. Now, at first glance on the PCT side, normal or abnormal?
It's abnormal.
Abnormal.
But it's
what would you do?
Tell the nurse.
Freak out, then go tell the nurse. Let her freak out or him freak out, okay? So you report that to the nurse. That's a problem. The underlying rhythm is what?
Abnormal. Like it's normally abnormal.
What?
Oh.
Sinus. So that, the underlying rhythm is still sinus. Here's these sinus beats over here, P wave. Okay? This is the escape beat. No P wave. So this is junctional. Don't let this throw you off here. It's still a narrow QRS complex. Okay? You can see the R and S wave. It's still narrow there. So this is an underlying rhythm of a sinus. It's for some reason it has this junctional escape beat. So I think this is what happened with this guy here. Okay? Up to this point right here, the SA node was depolarizing. Everything cool, right? SA node depolarizing, everything good. Uh-oh. No response from the SA node. Okay? So to keep everything going, the backup system that we talked about, right? This junction, the AV node is going to depolarize. That's why it has an intrinsic firing rate or depolarization rate, right? So this junction depolarized right here. It got tired of waiting for the SA node, so it depolarized to send a signal down to the ventricle so we could have some contraction. Good? Oh. Now the SA node started working again. Okay? Once, this happens once, not a huge deal. This happens once every 6 seconds, because this, remember, 6-second strip, right? That could be a problem. All of a sudden your SA node is stopped. It gets real erratic, because it's supposed to be what? The rhythm of the firing rate of the SA node.
Oh, yes, I know it's 60 to 100.
Yeah, the rate is, but the rhythm is, starts with an R. Regular. Right? The rhythm is regular. Okay, it's a regular. This is irregular. So this would be a problem. Eventually, you know, more than likely, it's going to be a trip to the cath lab to figure out what's wrong with this patient. Okay. Anybody want to be a cardiologist? They call you in. They say, "What's wrong with Bob? He keeps having these sinus pauses, but with this junctional escape beat right here." This is going to, if this happens over and over, what's that going to do to your patient? If this happens over and over, what is this going to do to your patient?
Like toward a signal sign.
Don't overthink it. You're right. It's going to decrease cardiac output.
Oh.
Yeah. See what I mean? It's going to decrease cardiac output. That's a problem. That's symptomatic. So that's going to have to take place. So they're going to have to call that cardiologist in and take care of that. Okay. So a junctional escape beat. So it's underlying rhythm, sinus, all of a sudden, boom, there's no sinus atrial node activity, so the junction decides to initiate a response, and it does, and it throws this junctional beat out there. Now you can have a pure junctional rhythm, which I don't think we have in here, but I'll show you a junctional rhythm. It'll just be a lot of QRS complexes without P waves. Okay, 40 to 60 beats. It's very irregular. There usually won't be a visible P wave in the junctional beat itself, and the QRS complex is still normal in width, less than 3 little boxes. Oops, wrong way. So here's some more. This is just some Tachycardia here, that the patient's moving or something like that. So you see these beats. It's really hard to just. This is the junctional escape rhythm. This So what has happened here is the SA node has stopped depolarizing. So it's the junctional rhythm. It's just starting. The AV node is depolarizing on a regular basis now because there's no SA node depolarization. Okay? This is a better rhythm. So when you look at this, here's the inverted P wave, absent P wave, absent, absent, and then here's one, well, no, never mind. There it is. Precedes. See, so the P wave is absent here. This is your ST segment. So this signal here, the P wave is absent. This is inverted right here. Do you see that? Where that P wave's inverted? And then this one's preceding the QRS. So you have them all three right there in the same 6 seconds. So there's a problem with the SA node. The SA node is depolarized here, but it depolarized too late. Is that confusing, or does that make sense?
It's good. I think
Yeah.
it's more like the identification.
Yeah.
What it is.
Don't worry too much about the escape beat or whatever. You just want to, this is your go-to for a junctional rhythm, okay? No P wave, inverted P wave, following the QRS complex. It's going to be junctional. And so a junctional rhythm just tells you that, hey, something's wrong with the SA node. Maybe there's a blockage there. There's not getting blood flow. It knocked the SA node out. Okay, there's an electrical problem for sure. Accelerated junctional rhythm, okay, just means that it's outside the norm. So it's 60 to 100. It's regular, okay. The QRS is normal, and the P waves might be the same. Let's look at what this one. That looks like a clean rhythm, clean junctional rhythm, okay. It's accelerated because 1, 2, 3, 4, 5, 6, 90. It's at a rate of 90. Okay? It's outside, it's considered accelerated because it's outside the intrinsic firing rate of the junction, which is 60 to 40. Okay? Picture that at 40. Okay? If you can, picture this part right here. Of course, they'd be all spread out, right? The QRS complexes would be spread out. But no P wave, no P wave, no P wave. If that was 6 seconds of EKG right here, then that would be a rate of 40-ish, because this not all there, but a rate of 40-ish, okay? And there's no P wave. So you can easily identify that rate, because if you use the systematic rules for interpretation, there's QRS complexes. Oh wait, there's no P waves. Once there's no P waves, there's only one rhythm that it is. It's junctional. Okay? Then you have to get the rate to see if it's an accelerated junctional. If it's greater than 60, it's accelerated. Now the next one's going to be a junctional tachycardia. Guess what rate that's above? 100, right. It's going to be about 100 because it's a tachycardia. Tachy means fast. Cardia, above 100. Same as a sinus tachycardia, except it's not going to have what? P waves. Okay? So this is accelerated because it's less than 100. Okay? And then you have a junctional tachycardia, which is 100, 180. This would be a different rhythm. I can't imagine it getting that high. Okay? But you see this, so it's 1, 2, 3, 12, so 120, a junctional tachycardia at 120. So you use those good rules of interpretation. Yes, there's QRS complexes. Boom. Oh, there's no P waves. It's junctional. Is it regular? Do the R's march out? Is this gap the same as this gap? Yes, you're right. It's regular. Okay? So even this accelerated junctional rhythm, it's regular. What would make it irregular? Well, yeah, I know that. But what cardiac-wise would make it irregular?
Like if there was another block, like something different.
Yeah,
A little section.
if all of a sudden there's a PAC involved there, right?
Mm-hmm.
So right in the center here, envision a P wave right here, okay? So that would make it irregular. That would be a PAC. So the underlying rhythm would be an accelerated junctional rhythm or junctional rhythm with a PAC. Does that make sense? So you have to look at the whole rhythm, make sure there's not any premature beats there. Because when we talk about PVCs in a minute, or ventricular rhythms, there could be a PVC there. They pop up. Okay? So junctional tachycardia. Can you have a junctional bradycardia? Rate less than what?
40 or 12.
Would it be less than 40?
Yeah.
Right? Sort of. I'm not even really sure there's actually a junctional bradycardia. You would just have a very slow junctional rate. I think after 40 it would work into a ventricular rhythm. It would be so slow. All right. Everybody good with junctional rhythms? Very quick, down and dirty, easy to interpret. PVCs, premature ventricular contractions. So we have PACs. PACs are going to be, they're going to have P waves in them. It's going to be irregular. The PAC, the premature beat, is going to make it irregular. Junctional, a premature junctional contraction is going to make it irregular. The PVC is going to make it irregular. Premature ventricular contraction. When we talked about those PACs, we talked about perfusing beats, remember? So you're sitting there going, ba-boom, ba-boom. You feel a pulse, ba-boom, 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 right? Then all of a sudden, ba-boom, 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 right? It's irregular. All of a sudden, it's irregular. So you have a premature beat in there somewhere. If you can feel the pulse, then it's perfusing. If you're looking at the cardiac monitor and you see a premature beat on there, but it doesn't correspond with the mechanical pulse, a palpable pulse, then it's not perfusing. Remember? Good. Sort of good review there. So PVCs, the difference is going to be the QRS complex is going to be wide and bizarre looking. Okay, wide and bizarre. So let's look at this. So this is, what's the underlying rhythm? Well, a sinus rhythm, right? It's an underlying, what rate? 1, 2, 3, 4, 5, 6, 7, 8, 9. So 90-ish. So the underlying rhythm is a sinus rhythm, but you have this, it's regular here to here, regular here to here. All of a sudden, from this QRS complex to here is irregular because of this PVC. Okay? It's wide, it's just right at maybe 3.5 boxes, so it's not too wide. I'll show you some other PVCs in a minute, okay, to clarify that, because they do look wide, wider than that. But this is called a premature ventricular contraction, or PVC. If this is perfusing, and you have 2 every second, you know, or 2 every 6 seconds, how many is that per minute? 20. 20 perfusing PVCs, maybe not a problem. 20 non-perfusing PVCs could be a problem. Okay? So, if you notice, these PVCs happen every 3rd beat. So it's regular. So boom, 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 right? So every 3rd beat. you have a PVC, so that's pretty regular. It's unifocal because it looks the same. Okay? Make sense? Unifocal, so it looks the same. Multifocal, this PVC would look different than this PVC. It's just meaning that it's firing from a different foci in the ventricle. Okay, but PVCs, we don't really worry too much about PVCs if they're perfusing. Non-perfusing PVCs we sort of worry about. If you had 20 PVCs per minute, we would call in the cardiologist because you're 17, 18 years old. Okay, that's not normal.
It usually happens with like older people?
Older people, cardiac disease, different things, blockages, different things like that, okay? For a young person to have all these PVCs, you would get that expensive bill.
Caffeine.
Yeah, no, not not the PVCs. Okay? So they're uniform, they're unifocal. PVCs means that they are they're from different foci. So here, this PVC, these are unifocal here, right? Where's the odd one? Yeah, right here. This is a PVC because see the QR hope on your certification exam that they have some wide PVCs. Okay, these are marginal. Okay, but these are multifocal PVCs. Just means that they're from different foci. They're from different points in the ventricle. Remember that those ventricle cells can fire independently. When they do, they create a multifocal. Underlying rhythm is what? Sinus. Correct. Okay. We won't get into. We'll skip this part. This is not really. This just means that R wave is up on the T wave. Okay. And these are your thing here would just be said. These are PVCs because they're wide, right? They're almost 4 boxes wide. Okay. So they're wide. So they're unifocal PVCs with the underlying rhythm of sinus. Just. That's messy. You can hardly see that, but when you have two PVCs together, they're called couplets. So if you have sinus PVCs together, 3 PV, it just changes things. So you get 5 or 6 together, okay. No. Then it just sort of it doesn't. It's not like adenosine. Yeah. So we have an less than 40. So you're going to have, okay. So you have for these ventricular beats, okay. The rate is in a normal, depends on the underlying rhythm, okay. So let's just look at one right quick. So you have sinus, sinus, sinus. The same thing with that junctional escape beat. Right? You have this pause here. All of a sudden, hey, what happened? It almost looks like it produced a P wave here. Okay? But then you have a junctional beat. So this is a sinus rhythm with a ventricular escape beat. Okay? It gets the escape beat from this pause. You wouldn't say that's a PVC. That is a PVC, okay? But it's a ventricular escape beat because the pause there. All right? Everybody good with that? And then the same here. You have 2 actually. But now here's the escape beat. This is a PVC. And well, these are both VDCs. So you're going along sinus, all of a sudden something takes place, the SA node is knocked out, the junction is not responding, the AV node is not responding. Okay, so you have an escape beat, okay? Oh, good, the SA node finally woke up and started working, okay? Happens once in a while, no problem. Happens all the time, problem, big problem, okay? Because now, with these junctional escape beats, we're down to our last line of defense, right? Our first line of defense was the normal CSA node. Then we have a backup with the junctional AV junction, and then the last backup is the ventricular response. Idioventricular rhythm, okay, 20 to 40 beats, okay, so this is the ventricles depolarizing. The SA node has stopped working, the junction has stopped working, we're in deep here, we have a problem, okay? This patient is about to die. If they have a pulse with this, it's going to be really faint. This is when they're feeling for that femoral pulse. More likely they've lost their carotid pulse. Okay? It's usually a regular beat, just really slow. There's no cardiac output. There's very little cardiac output at 20 beats per minute. Okay? That's 2 complexes every 6 seconds. So may or may not have a P wave. Definitely going to be wide in bizarre. It's going to all these ventricular rhythms are going to be wide. And then there we go. So rate of what?
20 to 40.
Well, this rate?
Oh, this is 30.
30? Yeah. Now, first glance, you could get that confused with what rhythm?
Oh, with the expression.
We just talked about it.
JVC.
Junctional. Why could you get that confused with the junctional rhythm?
Because
There's no P wave, correct. Okay. Why is it not a junctional rhythm?
Because
2 reasons.
T wave is inwards. No.
Why is it not a junctional rhythm?
Oh.
Well, it's not a P wave at all.
Yeah, the rate.
Huh?
The rate.
The rate?
Uh-huh.
The rate is too slow. It's at 30. Okay? It's not the junctional 40, 60 to 40, and the big one, and no. The QRS complex is wide. Remember the rules for interpretation on a junctional rhythm. The QRS complex is narrow. It's in normal limits. This is wide. This is ventricular because the QRS complex is wide and it's slow. So the rate and the wide QRS complex. In reality, these things are going to be super wide. Okay? Because we're going across in time here. Okay, and you have a big delay. Anytime that you get down into the ventricles and you have a delay, it's going to widen out that QRS complex. Right? Idio means false. Okay? So false ventricular rhythm, or it's going to be real slow. If this doesn't have a pulse, usually this doesn't have a pulse. It doesn't have a palpable pulse. When you have an idioventricular rhythm, this patient, you're going to start compression zone because they're not going to have enough cardiac output at 30. Okay. This is when they bring in the Doppler pulse and try to hear it with the Doppler. But more than likely you don't start compressions there. They need to speed up the rate. They need to figure out what's wrong with the SA node, okay? But this is sort of a last ditch effort here to for life. But you're going to get your workout there because you're going to start compressions. Okay? So the idioventricular rhythm. These all are going to take some time for you to actually look at, right? And study the interpretations. Just remember these ventricular rhythms, it's wide. These are going to be wide. The QRS complexes are going to be wide. Accelerated, what does that mean?
Faster.
Yeah, it's going to be faster than 40, right? You have to remember the intrinsic firing rates of these, of the SA node, the AV node, and the ventricle. Because accelerated just means it's going to be faster. So this is at a rate of what? 50. Okay? It's not junctional because of the rate. Again, it's not junctional because of the rate and the wide QRS complex. So let's go back right quick. Narrow. See one small box in width, right? See the difference in narrow and wide. So you got to sort of get that there where you can recognize that wide QRS complex. So this is just an accelerated idioventricular rhythm. There could be a pulse with that, okay? But again, it's down to the last sort of ditch effort for the heart to contract. This person's going to the cath lab. They're going to have to figure out why that they have that idioventricular rhythm if they still have a pulse. They may not have a pulse with that either. Okay. Oh, good with those rhythms? Ventricular rhythms are easy. Wide QRS complex. VTAC, 100 to 250 per beats per minute. It's a regular rhythm, okay? You may not be able to see P waves because they're so crammed together, okay? There's no PRI, everything's all crammed together. At 250 beats per minute, it's all crammed together, right? Mm-hmm. And the QRS complexes are going to be wide. They're going to be wide because it's ventricular. Everything that's ventricular in nature is going to be wide when we're looking at the rhythms, okay? VTAC, easy to remember, okay? You look at that, what's that rate?
170.
2 maybe. I counted it.
Oh, you count on your pack? Okay. I was like, hey, girl, man, you're fast. 190, okay. 190, right? There's no P waves because they're all, if there was a P wave, it might be crammed down in here, but it's ventricular in nature. It's wide. Here's the width of the QRS complex here. See how wide that is? Okay? So it's VTAC. It's monomorphic VTAC. Means that these all look the same. Okay? That's what that word means. It's all these ventricular beats are the same. Now you can have VTAC with pulse, VTAC without a pulse. VTAC with the pulse, you're going to have to fix it because you're going to really drop cardiac output here, right? At 190, you're not going to have, plus you're not going to have very much cardiac output. So you're going to either have to, an unstable patient, you would synchronize cardiovert it. In a stable patient, then you would give an antiarrhythmic drug, okay? Just like SVT, same deal. So unstable, which most of the time it is unstable, you would shock this. You would synchronize cardiovert. Everybody remember that? Synchronized cardioversion? Okay, you would synchronize cardiovert this. Without a pulse, you would defibrillate it. It's one of the two shockable rhythms. What's the other shockable rhythm? V-fib, right. So V-tac without a pulse, lethal. It's shockable, right? V-tac with the pulse, it's going to be lethal if you don't fix it. Okay, so stable patient, you can do some drugs, antiarrhythmic drugs that we're not going to get into right now. Okay, unstable synchronized cardioversion. More than likely they're going to do a synchronized cardioversion because if it's stable, it won't be stable for very long. So V-tac, everybody should be very good with V-tac. It's one of the most recognizable rhythms around, except with polymorphic V-tac. This is not the they term it this, but this is the most common term for it is torsades. Torsades de points. It's French, right? It means turning of the points. If you visualize that, can you see the way that sort of those points sort of turn? I don't know. It's hard to here, then it turns here, then it here, then it turns here, then it turns. Okay. You would treat torsades. Now, you just have to look at it long enough to say, oh yeah, that's torsades. Because it's not that, right? It's that torsade. So it looks like V-tac and V-fib mixed in together. Okay? The good thing is you treat it like V-fib because it's shockable. You'd shock this. You'd treat this as V-fib and defibrillate it. They're not going to have a pulse with torsades. Okay? So that's sort of a rare. I've seen torsades maybe like once or twice. One time it was, I don't guess it's too funny, but a lady had a heart attack in a haunted house. Okay. And while we were there, we were doing the 12 lead and everything. It was showing ST elevation. She was having the big one. She was having the MI. And then in another lead, it started showing, because we had the 12 lead hooked to her, right? This is what's cool about it. In another lead, it started showing torsades. And we went, oh. And then just like a second later, she went, oh. Right? She went to cardiac arrest. Put the pads on her, and then defibrillated her once, got her back, and then talked about it forever because she literally had a heart attack at a haunted house. And so anyway, torsades. You can polymorphic VTAC is probably the technical name for it because these are different. Okay, they're from different parts of the ventricle, but it's torsades. Remember torsades. I don't know anybody that calls it polymorphic VTAG, except whoever made these slides. Everybody good with torsades? It's just a matter of looking at the rhythms, identifying the rhythms, okay? And then something you should be very familiar with is V-fib, correct? Ventricular fibrillation is the most common rhythm in cardiac arrest, sudden cardiac arrest, okay? There's no discernible P waves, no discernible PRI, no discernible QRS complex. It's considered chaotic, a chaotic rhythm. Both of these are considered V-fib. So you look at this, there's no QRS complexes, right? This is considered V-fib as well. It's just too slow for V-tach. It could almost be considered maybe a little torsades, but we don't want to split hairs, right? Okay, so V-fib, they have some people term it fine V-fib, which would be this. and then VFib, ventricular fibrillation. This is probably more common looking, okay? But it's very recognizable, correct? So if you go into the room of your patient and you see this on the monitor, what would you do? Huh? Code blue. Call a
I was about to
code.
say that. Press the blue button.
You would call a code. This is VFib. This is lethal. Okay? Definitely, you wouldn't calmly walk down to the nurse's station and go, hey, by the way, I think Mr. Smith and 205's in VFib. They'd be going, what? So, call a code. It's VFib. If you're at the hospital and you're in the ER room and there's nobody else in there and you're waiting around checking things out and you look up at the cardiac monitor and you notice this, what do?
Yeah, press the blue button. There's no one around.
You go back out and say, call a code. The patient's in VFib. Okay? It can happen. I mean, it can happen like that, okay? You know, the nurse leaves the room, you know, you waiting there for them because things are taking place and there's nobody in there except you. Have you ever been alone with the patient in the room? Yeah? This, call a code. Don't be shy about it. Okay? Use that outdoor voice of yours. Open that door and say, call a code. We have the patients in VFib.
I hate how sometimes the monitors aren't good though.
Right. If the
We try to tell them, they're like, oh, it's just the monitor.
Well, that's true. Because, hey, if the patient's looking at you and talking to you, they're not in VFib.
They need to be dying, bro.
If they're breathing, they're not in VFib. Okay? This is lethal. This means that there's no discernible pulse. There's no pulse. VFib is just a quivering of the heart. It's not going to produce a pulse. Alright? This is shockable. If in doubt, get a nurse, right? You can check the patient right quick. Are they breathing? Oh yeah, they're breathing. It just must be the monitor. Okay? You're quite overqualified to do that. You're quite capable of that. When in doubt, inform the nurse. It could be VFib. If you don't, what are they going to say to you?
What were you doing?
Why didn't you come get us? Yeah. Why didn't you come get us? Why didn't you come get somebody? Right? So
they looked at me. They were okay.
yeah, I mean, if they're talking to you, they're not VFib. Okay. What I used to do when I trained paramedics, the red lead here, I would distract the trainee or something, and I'd reach over and I'd pop the red lead off and let it fall down on the ambulance floor and bounce.
Oh, me.
I know, but it looked like VFib when it did that, and those guys, their eyes would go, and I go, get the paddles, get the pads, and the patient's going, what? You know, they're looking at the guy, and the trainees want to put on the pads and get going, right? And the guy's going, hey. I'm like, okay, before you open that $30 pair of electrodes, calm down, unkey, and figure out what's taking place here. Is this patient really in VFib? Yeah, we could look at the monitor. So we go back to that common expression, treat the what?
The patient.
The patient. Always treat the patient. Your patient is looking at you, and you're scaring the daylights out of them. Okay?
Maybe then they'll have beef.
Yeah, then they go into VFib or VTAC. You know, you scared them into a lethal rhythm. Okay? All right. So we're good with VFib. we should be good with asystole, right? Flat line, no ventricular response. There's some P wave responses here, okay? But, well, they call it P wave asystole. But asystole is flat. It's not a shockable rhythm. You do not want to shock asystole because you increase cardiac, the impedance, you increase the resistance when you shock a non-shockable rhythm. So if you shock asystole, you increase cardiac impedance, which means you increase the resistance of that electrical current, which is going to hurt the patient as far as getting if they do go into V-fib, you've increased that resistance to the defibrillation, to the stimulus. So on TV, they shock asystole all the time. You look, they're in the code, shock them. And they sort of pan over to the monitor, and everybody goes, no, they're in asystole. You don't shock asystole, right? You would shock V-fib. That on the monitor, you'd shock that. Okay? No shock. Drugs, epinephrine, first line drug. Anyway, no systole, asystole, no ventricular contraction. No problem with asystole. This is usually slower when we get into this. Pulseless electrical activity, PEA, means that they have electrical activity. Their SA node is firing quite well, right? At a rate of what? 140. Usually, I mean, PEA is usually going to be slower, but if you looked at that, that's a sinus tachycardia, but it doesn't have what? The patient doesn't have what? A pulse. So this guy's not looking at you, smiling, going, hey, glad to see you. This patient is unconscious, unresponsive with this on the monitor. Unconscious patient, what do? Well, no. First thing you want to do is what? Check a pulse. ABCs, right? CAB, right? Check a pulse. If they don't have a pulse, but they have this, then they're called PEA, pulseless electrical activity. It's a very lethal rhythm. Last thing I read on it was that in the hospital with the medication in your hand, it has less than a 5% survivability rate. The electrical system's working great. Something mechanically is wrong. So the muscle itself is damaged some way. Okay? So PEA, pulseless electrical activity. No pulse. Very good looking sinus tachycardia here. Like I said, usually it's going to be slower, but a very good sinus tachycardia. But no pulse.
So how do you treat that?
The same way they treat asystole medication, epinephrine. Okay? You start CPR and they start administering epinephrine. They want that muscle to contract. Okay? And here's some causes. You can P-hatch or P-patch, or they have all different kinds of things that causes PEA. You don't need to remember this by any means, but pulmonary embolism, acidosis, tension pneumo, tamponade, hypovolemic, okay, for some reason, hypoxia, heat, hyperthermia, hypothermia, or kalemia, hypokalemia, then infarction, drug overdose. So there's several different causes of PEA. What they will do, if they have this, they say, oh, there's no pulse. Okay, you may hear the doctor running down a checklist. Okay, the last patient that we had in the hospital had PEA, and the doctor did that. They ran down a checklist. Okay, acidosis, they gave them sodium bicarbonate. Okay, they didn't do anything for the tension pneumothorax. They didn't decompress their chest. Okay, hypoxia, they were bagging them. They checked make sure they had a good SpO2, good waveform. Okay, they did put heating measures on them. Okay, they drew lab. Look for this. They did a 12 lead. All right, and then they administered medication in case the patient had an embolism. The reason that they did so much was this particular patient was 22. Okay, an old geezer like me, they wouldn't do that. They wouldn't do that much. They just like, sucks to be you, you know. But they went to almost all those extents to figure out what that PEA was. All right, so next time we have our last deal in EKG. We only have one more lesson in EKG, and that's heart blocks. Okay. Like I said, hopefully, normally on the PCT exam, you just have to identify what's wrong, what's abnormal, and that would be the easiest thing. This is abnormal. Okay, so I don't know. I'll let you know when I take the test if there's interpretation on it or that. But we, for now, learn the interpretation. You'll need it eventually. You might as well learn it now. Oh, and you'll be tested on it. So.